Hi, my name is Dr. Shoaib Malik. I'm the oral maxillofacial surgeon. This presentation is about medical consideration for implant dentistry. And in my view, I've read many books regarding implant dentistry, attended some lectures, and when it comes to this topic, most try to concentrate on teaching us kind of superficial way all the medical conditions, for example, diabetes, type 1, 2, hypertension, chemotherapy, whatever it might be. They give a brief view about the pathophysiology and they kind of move on to the next topic. And while sitting in those lectures or reading those books, I realized it really is not benefit to kind of get that superficial idea what the condition might be, because the part that really affects is usually very deep. Each of those diseases, you can write a book on it. So, that part of it, I'm going to try to pass it on you guys on your own. That if you're really interested, let's say, learning about type 2 diabetes or thyroid problems or whatnot, please find time. It'll be well worthwhile for you to gain that knowledge up. But what I think be really beneficial for you is to find some type of collection of literature review and let that speak for itself and give us a suggestion in how to treat those patients. And I think this is kind of what we're looking for because our program here is basically set up so you can be somebody who's very particular about learning about implant dentistry. Not trying to make you a primary care physician or not. What is relevant to implant dentistry that when you see that patient on your chair, what knowledge am I giving you that's going to help you right away understand, quickly make that decision? So what I'm doing right now in this chapter would be to basically do a nice systemic uh, literature review. And based on those reviews, we'll make some suggestion in how to treat certain kind of medically compromised patient. We've also done, I believe, a very good job in referencing. So if you find some article that you find was very intriguing, you can always go back and read the whole article up so you can get a really nice picture, not just the fact and what they're recommending. So before I start, there are certain key points I want you guys to understand. And these are very important. This evidence-based review summarized information on dental implants that was published in around 2004. It is not intended to replace your clinical judgment or be used as a clinical protocol all by itself. If it was that simple, we wouldn't need physicians because everything is just black and white. It's not. Things like bruxism or other parafunctional habit that can also affect, for example, our bottom line, not just medical consideration, is not considered in this topic. And some of these can actually overlap. So, for example, somebody who is a smoker, who's a diabetic, and was on bisphosphonate. Now, each one of them might not be contraindication for implants, but put them all together, looking at the patient, how he's a chain smoker, and he might not quit or even cut down after implants, could be a contraindication, knowing that you have a unique patient on your chair and you are actually seeing him and making a decision. So the idea of this presentation is to give you fact and make suggestion, but keep in mind the bottom line is your interaction with your patient and your clinical judgment. And this presentation is also very statistically based. So if you don't get lost, just to make sure you guys don't get lost, I put some definition down, a coherent study, panel study. I'm not going to go into details here. You can pretty much just pause this presentation and kind of get the definition for each one of these things. Same thing with systemic review. Sorry about that. What the definition of case series would be, clinical series, the narrative. So, the odd ratio, please make sure you can pause it. If you choose, you want to really get in depth with the statistical part and you want to understand not just the conclusion of these articles, but what exactly method they use, if they're biased or unbiased. Please make sure to have a good, so that definition is going to help you out understanding that part of it. So let's get to the subject matter itself. So the first thing I picked was the effect of smoking. And this is, not just from the doctors, from the patient, from my GP. It often kind of comes up. What kind of a contraindication the effect of smoking would be? So this is the example how the rest of the presentation is going to be. We found out there are about 37 papers that were reviewed that evaluated the effect of smoking on implant, its survival and success rate. And based on these studies, um, the three systemic reviews, they all found that smoking significantly increased the risk of implant failure. They estimated the pool difference in survival rate between the smokers and non-smokers to be 2.98%. So think about it. If our implant success rate is about 98%, on smokers it'll be about 3% less. These studies also found out that there was a significant increase in the risk of failure of implant placed in the maxilla compared to the non-smokers. So it also shows us that maxilla is more prone to it. So when you, for example, thinking about placing an implant on a patient that is a heavy smoker, be careful when you're talking about um, on placing on maxilla, especially if the patient is a heavy chain smoker. Now, again, is 2.98% make something a contraindication? Absolutely not. But at the same time, as a doctor, when you're doing your consultation, you need to present that to your patient. So they're educated that they're putting themselves in that risk category, but at the same time, it's still a very high success rate, even with the 3%. But they need to know that they're a contributing factor if the implant, there's a reason for an implant failure. Also, on the odd rate, there was no significant increase in the risk of failure of implant placed in the mandible of smokers compared to not. So majority of the effect that was done, or smoking had, I'm sorry, was on the maxilla, not on the mandible. And the study kind of mentioned or suggested that the smoking has more influence on implant placed in the maxilla. Okay, so it's a good little point to have. People who smoked between 10 to 20 cigarettes per day had a statistically significant greater risk of early implant failure compared to people who don't. So now, within the people who are smoking, obviously makes sense. If you're going high a pack a day or half a pack a day, you'll be definitely in higher risk factor compared to people who are socially smoking, let's say one or two. And those that smoke greater than 20 cigarettes per day, obviously, same kind of theme. They were even in a higher risk factor. It also shows smokers had a significantly increased risk of overall complication, which also means inflammatory complications, implant failure due to mobility, pain, infection. It also shows smokers had a high risk of implant failure, and when they defined failure as actually removal of the implant itself. The other thing we have to think about too is exactly at which point of implant placement, osseointegration, covering, or prosthetic does the smoking has its biggest effect. So studies show that smoking increased the risk of early failure from 1.12% to 5.56. So among the failures that you have, the most impact the smoking does is on the earliest part of the implant placement. So smoking at the time of implant placement surgery increased the risk of early implant failure, and that a positive smoking history was associated with late after the prosthesis was filled implant failure. So what does that mean? That it does have effect in both part, even the starting part and even after the prosthetic, but the main part, or statistically main difference, would definitely be in the starting part during the healing phase, the osteointegration phase. The next thing we're going to talk about, like we talked about initially, that you can take each of these compromised situations where the patient is either smoking, or have some other medical issues like diabetes. Together, you have an add-on problem. So if somebody is, let's say, is a smoker, but they also have a history of osteoporosis. So we also had study on patients who are smokers, with a history of osteoporosis, and the study states that the effect of osteoporosis on implant survival in a woman found that smoking increased the risk of implant failure. So again, this kind of makes sense because later on when we're going to talk about osteoporosis, you see that as there are some patients that might have some effect in increase in implant failure. Now, again, that doesn't mean it's a contraindication. Absolutely does not mean that way. But in a placebo type setting, if somebody who has no osteoporosis or non-smoker, you'll see some difference, even though the difference might be very small, but it does exist. And the patient need to know about it. And when you're doing a treatment planning, you need to have that consideration in there that, hey, we're still in their 90s, 95 success rate, or 97 success, 98 success rate. But you need to be aware by doing this, you're increasing the risk. There was also a large study found that the risk of failure was increased by 1.39 times in smoker. Now, again, 1.39 times, seems like a big number, but you have to remember if you already if your failure rate is pretty low, maybe 2% or less than that, statistically, that's not such a big number. It's not like, again, it's a contraindication. But again, the patient needs to know. There was another study that assesses the long-term survival and risk factor for implant failure of screw-type implants in a private practice found that smoking increased the risk of implant failure by 0.04%. So there's some consistent number about long-term studies, even though very small, but it does play a role in it. So again, we already kind of made this statement, but this is a more of coherent study, which came basically to the same conclusion. We also had a study that investigated the survival rate of dental implants in people who have had a successful dental alveolar reconstruction procedure, found that the risk of failure in smoking was increased by 4.4. So, which kind of also makes sense because now you already are in a compromised situation where there was already a reconstruction done, and now added to the fact you're placing implant and smoking, so you expect a little bit of a high incident than somebody on a native bone or a normal situation when you're putting the implants. So using the ACC dental implant evidence-based review, they concluded, which kind of makes sense, and that's what I've been trying to preach throughout this smoking part, is that the smoking as a single risk factor may not increase the risk of implant failure sufficiently to deny treatment, but the dental implants may be contraindicated in smokers who have other relative risk factors. So just kind of review what we just talked about before, that yes, it does play a role, but not significant enough that you're going to deny your patients the dental implant treatment, but you should have in the back of your head what it is. Also, at the same time, keep in mind, even though we talk about the osteoporosis, putting together, but in general, this is just for people who are smoking. And if there are other issues that are involved, smoking at that point could become the tipping part of it, where you might say, okay, patient has bad oral hygiene, uncontrolled diabetes, and now they're a heavy chain smoker. Maybe that's it. Maybe you should not want to proceed with the implant, option. But keep in mind that these studies are more than well related to as smoking by itself. So after reviewing all this, it kind of strengthened the evidence base for smoking as a risk factor for dental implant failure. So we know that it has a slight, increases the slight high risk for dental implant failure. And it's reasonable to conclude that the implant survival decreases about 3%. So that's what you're looking at. There is also more evidence that there's some dose dependent that we talked about. The more you smoke, the 10, 20, and even more than 20. So kind of divided between three parts, less than 10, between 10 and 20, and greater than 20. And you can define that to your patient as the same way, that within this 3%, it could be, you're on the high end of 3%, let's say if you're 20 and above, or low end if you're smoking less than 10 cigarettes, let's say, per day. So to kind of conclude this, that there is a moderate evidence that smoking reduces implant survival, but the effect size is too small to deny your patient the treatment of dental implants. So our recommendation based on the ACC is smoking less than 10 cigarettes per day as a single risk factor may not increase the risk of failure sufficiently to deny treatment. And we believe the dental implants may be contraindicated in smokers who have other relative risk factors. So if you have somebody who smokes, let's say, more than 20 cigarettes a day, and like we talked about, based on your clinical judgment and other issues, could be contraindicated, but by itself, it is not. Next, we're going to talk about osteoporosis. And again, I'm not going to go over the disease by itself. We know this is the issue that after postmenopausal affects females, but obviously I've also seen male patients being affected due to various reasons. But if you feel like you need to know more about the disease, you're more than welcome to go and look it up. But in this case, again, we're concentrating on the literature review about how this directly affects your implant and what kind of decision or tools you have to make that decision. So anyway, all these references are there at the end. Please go back and check it out if you want to individually take a look at it. I recommend it. It gives you a good idea also. But again, to help you guys out, we've done a good summarization thanks to the ACC Dental 2004. Anyhow, so there were 7 papers were reviewed that evaluated the effect of osteoporosis on implant survival and success rate, including 6 coherent studies and 1 case-controlled study. So, Al-Sadi in 2007 found that osteoporosis significantly increased the risk of early implant failure. The OR value was 2.88, whereas Al-Sadi in 2008 found that osteoporosis did not significantly increase the risk of late implant failure with OR 2.73. So you see, even after his own study, there was a change of opinion by itself. So that itself gives an idea how valid or the osteoporosis effect on implant dentistry might be, because you have 2 studies, one say might be, one say it does not. Another study by Al-Sadi 2008 reported that osteoporosis was not related to early implant failure. However, there were no failures in the group with osteoporosis. So, kind of agrees with his own part earlier that there was not much of a difference that he saw at all in patients with osteoporosis. There was another smaller coherent study found that neither osteopenia or osteoporosis significantly increased the risk of failure, both OR less than 1 and 1.14. So low risk factor in there compared to the control of what do you expect. In the only case-controlled study that we found, osteoporosis did not significantly change the odds of failure. So the only case-controlled study that was performed, the one controlled study, the osteoporosis had no significantly change in implant failure. Wood, in his 2004 article, concluded that there is no evidence for systemic osteoporosis being a risk factor for implant failure, but that for a patient with extreme osteoporosis, it may be wise to caution with maxillary implant treatment. Okay, and I'll go over that a little bit, why maxillary implant with osteoporosis, especially since we already have our bone physiology lecture and anatomy and also our radiograph lecture, and we talked about the effect of in the maxilla versus the mandible, the D1, D2, D3, and D4 bone, and we kind of quantify the type of bone we have in maxilla, which is compromised due to the Heimsfeld unit and the lower density and less cortical bone. So it kind of makes sense that when you're talking about calcium, and which is mineralized, and the problem with osteoporosis is about the calcium turnover, how area where there's already less of a cortical bone would be more affected than the mandible, which has more cortical bone, and losing some calcium, some of that mineralized would have some effect, but not as much effect in already compromised 3D, 3D4 bone in the maxilla. So this, logic proceeded and kind of makes sense. Another study in 2007 concluded that osteoporosis alone does not affect implant success. In 2008, lists osteoporosis as a condition that increased the risk of implant failure and suggests consideration of calcium substitute, a long healing period, and avoid of high torque for abutment screw. So you can see now, when you have all these studies done, that this is why it is nice to see a nice review, because you see all aspects of it. You're not married to one study and one conclusion. You'll actually look it up and see, hey, what has this man's had? Was it a certain type of population? Was it the age? Was the reason? All this might be a part of the reason that his group might be different, or it could be the type of implants that you're using. Because as we talked about it, the type of implant also makes a difference when you're doing implant, and what kind of primary stability you're going to use. So there are other factors that are involved, which might lead to a little bit of a little different result in some studies. So we're trying to look at an overall theme from all these studies that are presented, and base our suggestion based on that. But at the same time, you also have to know what other people might have a unique experience, which could be something that you might have to face, so you have to be prepared. Porter in 2005 found few published clinical studies on the topic of a little bit of conflicting opinions, and concluded that the visual assessment of bone density at placement may be more pertinent to implant success. So basically what he said that, like I was talking about here, the effect can be seen on the radiograph, and based on that you can kind of conclude that, hey, is it going to be success or not just based on is the patient osteoporotic, but kind of looking at the mandible itself, and the quality of bone, or the maxilla and quality of bone, and use that more of a factor than just kind of labeling somebody at osteoporosis. So I'm kind of giving you an all-out view on what the literature review is all about here. Scully 2007 in his review found similar success rate in people with osteoporosis compared to without it, but adds that sinus lift may be contraindicated. So again, you can see all these little twists in each of these studies. So if you're waiting, if you're facing some kind of unique issue, you can kind of go back and kind of, use this information to educate your patient yourself in patient with osteoporosis and where the problem might be or might not be. But I think the overall theme, you can still see that it is not a contraindication. It does affect minimally sometimes the success rate in areas where would you expect, which would be the maxilla, because that's where the weak bone is to begin with. So our suggested recommendation is there's not enough evidence, because you saw there were both sides, that osteoporosis is a relevant risk factor for implant failure. So my suggestion is do not treat these patients as a contraindication, just like we talked about smoking. My anecdotal experience with patient with osteoporosis is, yes, when you do place the implant, it's definitely a different type of bone. It's more brittle, at least from my experience, and the primary stability is not there, which is expected, like I said, because there is a calcium problem, and these patients, calcium helps in the cortical bone, which gives us that primary stability. So you lack that primary stability when you're trying to place the implant, and I'm very cautious of it, especially if I'm doing immediate loading in these patients. So right after that, I've placed bisphosphate associated osteonecrosis, and it's been kind of in the past, maybe almost like a decade, 5-10 years, this has been a hot topic when it comes to implant dentistry, and in general. Even now, there are some of my referrals or people that come in and we kind of communicate. They really do not understand, the effect of bisphosphonate on patient's bone. And even when you're taking simple teeth out, when you have somebody who's on bisphosphonate, how it can affect and cause osteonecrosis, which could be really traumatic and problematic for the patient if the necrosis really happened, and then you have to go through stages and clean it up. And I've done that as a surgeon. I've taken these patients to the OR. Is really a tough ordeal to deal with when that happens for the patient. And sometimes it's been for a simple extraction as number 31. So what I did here is there's a link right here. It's in the ADA, and the ADA has a paper written on it, and then they have their own recommendation. So I'm going to go over it, obviously, but I strongly advise you to kind of read this up. Click on this and copy paste, print it out, read on it, and it'll give you a nice, good picture, even as a reference to what to expect with these patients and what the standard is. And it is a position of the ADA, so you know exactly what the gold standard is, and you don't want to deviate too much from that position. So that being said, also get yourself familiarized with these names. We heard about Fosamax, Benivia. Some are oral, some are IVs. There's a pretty big difference when it comes to osteonecrosis developing on patient with which kind of medication after a surgical procedure. I have these lists to my assistants and everybody, so as soon as they recognize these medication, there should be a red light that should pop up. And the other extra thing I want you to remember is that these medications have a long-term effect. So a lot of time when you're asking your patient and they're like, when you're saying, hey, what medications are you on? They're not going to mention this, because if they have taken this, let's say they took Fosamax in the past, and you ask them what medication they're on, obviously they're not going to mention it. So you not just have to make sure that it's current, you have to dig back and be a detective and find out if in past they have taken it. So if you find anybody at the age of postmenopausal, please ask them regardless if they have taken it or not. And patients who kind of go through this treatment, they do remember it. Because the doctors usually go over the risk and benefit part of it, so they kind of do remember it. So again, make sure you ask them. Don't wait for them to tell you about these medications. All right. So there's some articles also I want you to read. Oral bisphosphonates and relationship to osteonecrosis for the dental implant. This is a good article. It's a review article, very small. I think it was only a page and a half. They have their conclusion that there is no effect to it. But there are other studies, and I have seen anecdotally patient with osteonecrosis after dental implants. And I still remember when I was in my residency, there was, we couldn't figure out why this certain patient population were getting their, not just implant failure, but the site where the implant was failed was being necrotic. There was dead bone all around it, and we were chasing it down and trying to figure out, what to do. And I remember Mark's article came out, very close to, at that time, his breakthrough article about it. And it kind of from there makes sense. And later on, when we talked about patient on bisphosphonates, and we're concerned about the osteonecrosis, which is the dead bone, how can we prevent ourselves from falling from the trap? And then Mark's had his article on the CTX testing. And this is a standard we use now in our practice. And we use the CTX to be able to give ourselves a high, moderate, or low risk for the patient who wants to get the dental implants. So just to give you a quick idea, when it comes to osteonecrosis, bisphosphonate, bisphosphonate usually affect the turnover rate of bone. So because the body in post-menopause, they don't want the calcium to leave the bone, they want it to be retained. So it helps retain calcium, mainly by affecting the osteoclast activity, which later inhibits the coming out of the osteoblast. So basically, the key aspect of bisphosphonate is the turnover. And when you don't have turnover, that means you don't have healing. And that's what leads to dead bone when you have no healing, which is osteonecrosis very differently from from the radiation where the blood supply is actually affected. So the blood supply causes the osteonecrosis part of it. But in bisphosphonate, it's actually the turnover of the osteoclast-osteoblast ratio. Or, I'm sorry, they're shaking their hand between each other that causes the problem. So, knowing that part, that is the turnover between the osteoblast and osteoclast, we can actually look at that turnover number and see how active that process is. If the process is active, we know that we'll have a good turnover, hence a good healing. And if the turnover is low, that means the osteoblasts and clasts are inactive and they won't be able to turn over and repair the process. So that's the kind of, in a very layman term, that's the reasoning behind this CTX text. So when you do take this CTX text, it's basically you write a prescription, and in the prescription it says, CTX 1 C-telepeptide, and you have to be morning fast. And I'll have an example later on. I'll actually show you a script of it in here. Excuse me. And if the test is below 100 pg per ml, you had high risk, which makes sense because, like I said, remember we talked about the turnover part. So if the turnover is very low, that means you're at high risk because the cells are inactive in that area or in that process. If the number is between 100 to 150, that's considered a moderate risk. And since implant is an elective procedure, right? You cannot justify high to moderate risk. You want to be in the minimal risk area because it is an elective procedure, and you don't want any elective procedure to cause long-term problems that make the situation worse. So the recommendation is if it's above 150, you are at minimal risk. And that's just not for dental implants. Any type of bony surgery you're doing in the mouth, which includes even something simple as taking the teeth out, this is exactly what we use. We wait for the patient to have their CTX done. If the number is about 150, we proceed on. Even at 150, we explain the patient the risk, but says, hey, it's minimal, and we can actually proceed to it. But below it could be a problem, and there are a couple of ways I'll tell you how to manage that if the patient is below it. The CTX values were noted to increase between 25.9 to 26.4 ml for each month of drug holiday. So what they're saying is for every month that you have your patient stop on bisphosphonate, they're bound to gain about 25 to 26 PGL. So if you're at 100, you assume within 2 months you'd be at 150. In 3 months, if it's a linear correlation, in 3 months you should be in the minimum. So that's what we call this a holiday period. The patient is on drug holiday. They're not taking that drug for a couple of months to be able to get the number back up, the collagen turnover ratio high enough, so there's a good healing after surgical intervention. It also mentions that CTX values rising above the 150 threshold were observed to correlate to either spontaneous bone healing, that's what we're looking for, or complete healing response after an office-based debridement procedure. So that, again, this is what we want. We want spontaneous healing, good turnover of osteoclast coming in, osteoblast, osteoclast coming in, removing the debris, osteoblast comes in, lay the foundation of the bone to osteocyte, same bone formation like we talked about in our lecture. So 150 we got spontaneous bone healing and good recovery after local debridement. So just to kind of summarize it, that if the patient is on bisphosphonate, again, by itself, it's not a contraindication. But we have to see what effect the medication had long-term on the patient or at that point. To have a good idea what that is, we recommend taking the CTX text. And based on the values, we will recommend it to be above 150. And if it is below 150, you want to wait patient with obviously you're going to talk to their oncologist or the endocrinologist, person who's managing their bisphosphonate to communicate with them if they can stop it for a couple of months so the numbers can go back up so they can get that elective procedure that they're looking for. And our goal is to get above 150 and have some predictable result. So just like we talked about osteoporosis, even on patient on bisphosphonate, you'll have, it's not a absolute contraindication unless we believe the number is above 150. And, again, when we talked about this is an isolated incident. Now, what if the patient is a heavy smoker, diabetes, osteoporotic, and was on bisphosphonate? That might change your feeling, especially, again, same thing when we're talking about the maxilla where the quality of the bone is not there. For me, I take all that under consideration, and sometimes even we'll start the surgery or we'll do our Heinz-Field unit and characterize the bone and explain the risk factor to the patient, or what could happen, that there might be implant failure, but at least by knowing this will prevent worst case scenario of osteonecrosis. So again, not an absolute contraindication, but if you take your step right, you should be able to have a predictable result. At the same time, these are also clinical decisions that you should make, which we'll talk about a little bit later on when we talk about patient selection for case selection for your implant. But if you can handle the complication, you should really send it out to a specialist, an oral surgeon who actually deals with these kind of osteonecrosis, because a regular implant failure, it should be within your knee, but something like this where you can actually develop the osteonecrosis can be a hospital kind of case that could be a big reconstruction or resection, I'm sorry, and be a big problem. So again, use your clinical judgment. If you cannot handle the complication, we always recommend send it to the oral surgeon as a specialist to take care of it. Next topic is about the effective age. We had 14 papers that were reviewed that evaluated the effective age on implant survival and success, including 12 current studies and 2 case series. Of the current studies, 11 found no association between implant failure and age, and 1 found an increased risk of earlier failure in those people compared to the less than 60-year-old. So vast majority evidence is associated that there's absolutely no difference. So there's no reason to be discriminative with age and tell your patient, hey, you're 70 years old. You don't deserve to have the same lifestyle as somebody who's 50 at that time. Of the 2 case series, 1 found no significant difference in failure between people of 59 and above, or people below 59 compared to 59 and people above 60. And the other study found no correlation between age and implant failure, but they didn't really report any statistic, if you can check our references, but they made their statement based on their observation. So we suggest that older age as a single risk factor, again, we're talking about single risk factor in each of these cases, unless I mention it, is not a contraindication for implant placement. And implant placement should be delayed in young people until the growth is complete. I think that's an obvious reason why, because as you're growing, your teeth are shifting, and if you have an implant, that can affect the shifting part of the teeth and could be a problem, as the implant is ankles to your bone, so it'll remain at that spot. Same reason why if somebody's having braces done, you want to put implants after the braces are done, when they make space for you, because once you place that implant, the orthodontist cannot move that implant because it's ankylosed. I briefly talked about osteonecrosis, and now we're going to go a little bit on the radiotherapy. So Lasati on 2007 and 2008 compiled a study on it and found that radiotherapy of the concerned areas, so let's say they had some parotid cancer or whatnot, or throat cancer, so areas that are affected where you're going to place the implant, they did not increase the risk of early implant failure. Then in 2008 in his A study, he found that the radiotherapy increased the risk of late implant failure. So There was no effect on the early side, but it actually effect on the late part of it during the part of the prosthetic part of it. Although this was only based on 2 people with 6 implants, so again, to give you an idea how what a low sample size it was, um, and keep in mind that a conclusion was actually based on that. Moy on 2005 also found that people who had history of head and neck radiation had a significant increased risk of failure. Okay. On the narrative review, Scully and Porter and Vaughan list radiotherapy as causing a reduced success rate of implants, as does Zedman in 2008. Moreover, Porter and Vaughan also and Wood both conclude that radiotherapy should not be an absolute contraindication, especially in the mandible. So again, we kind of talked about, is it lower the success rate possible? As you talked about, some of these studies have shown there's definitely a statistical difference between patient who had radiotherapy and who didn't. But again, not enough to cause it an absolute contraindication. But lowering your threshold in success rate, you need to talk to your patients about it so they're prepared about it. The concern about radiotherapy arises from, again, like we talked about, unlike the bisphos osteonecrosis, which was bone-related, right, the turnover, the radiotherapy, the radiation affects the salivary production, blood supply to the bone, which is the main reason, in the soft tissue risk, obviously. So the osteoradionecrosis is what we're concerned about in these patients, and we're going to talk a little bit about osteonecrosis in a bit of a second. The evidence above suggests that a history of radiotherapy to the area where an implant is to be placed may be a risk factor for late implant failure. And this is iterated in the narrative and review literature. So the unique thing you have to learn about this one is that if you do see implant failure in these patients, it'll be on the late part of it. And it could be due to, like we talked about, the blood supply and the xerostomia, the dryness of the mouth, where once the implant is being loaded, the stress has been on, and the mandible might not be able to handle it or repair it well enough. Or when you have sorry, when you have xerostomia and lack of saliva, that can make you prone to more inflammation and infection, so you can have those problems later on as the implant, even though if it's integrated, you can get a periimplantitis around it and plaque and whatnot. So be very aggressive in getting these patients back and make sure you do a nice cleanup job. So even though there's low saliva, you should be able to clean them up more regularly than your regular patient who had implants done. So our suggestion is there is some evidence that the implant failure rate in the maxilla are usually significantly increased in the people who have previously had radiation done. And obviously it's also dose dependent, because that's higher the dose, obviously the more destructive the effect would be. But there's also a common theme you're looking at, which kind of makes sense, how maxilla tend to be more prone to these medically compromised patients because it already is a compromised area, and not compromised and say that you can't do it, but relative to the mandible. The success rate is amazing on both of them, extremely high. But just in relative to the mandible, it's more vulnerable. And which, hopefully now it makes sense and you can see a bigger picture, because we talked about bone physiology, we talked about radiograph analysis using Heinz-Feld unit, and putting those two together, you should have a picture in your head why, and think like a surgeon, like why it would be compromised in the maxilla. And then once you have these patients with these medical compromise, you should be able to better talk to them and make them understand the risk factor without telling them, hey, you just can't have the implant, because they are not contraindication by itself. So one of the key things also we suggest here is that anybody who had radiation done, personally I feel like this should be referred to your oral maxillofacial surgeon, because the complication, if it does happen, just like with osteonecrosis, could be a big problematic. So, but at the same time, if you feel like there's a way you can, or you want to manage it, you completely understand it, and you have a good relationship with your oral maxillofacial surgeon, there are some guidelines that we recommend. So, patient who had radiation done, and they, you're doing your initial clinical exam, they're like, yeah, doc, 80 years ago, they found something on my neck, and, they started out with chemo and radiation and whatnot. What do you need to be, what information are you looking for? Well, the first thing you want to know is what's the total dosage and what is the field of the radiation? So, where was the radiation done and how much dose was provided? If the patient received more than 6,000 4 months after radiation or thereafter, then our recommendation is the patient should get an HBO treatment prophylaxis beforehand. Our suggestion is to have prophylactic HBO treatment if the field of radiation is equal to or greater than 6,000. So you call the radiologist up or an oncologist up, and then they're telling you, yeah, in 2004, he had 7,000 CGYs on his posterior of the maxilla or anterior of the maxilla. Well, at that point, the patient should have a prophylaxis HBO treatment done before you touch that patient. And we're going to go a little bit detail about that. Now, below 6,000, you have good predictability. You should be able to do implant surgery in a predictable fashion, and already talking about the slightly high statistical failure on the maxilla, understanding that, right? So you have that complete, but if it goes above 6,000, it's a totally different story. And again, I would recommend having those patients sent to your oral maxillofacial surgeon, but if you're in touch with them and you feel like you can handle it, and it's your clinical decision that you want to take that patient. So, what is HBO? It's a protocol. The HBO protocol is prophylaxis to do 20 treatment before and 10 after. And in the HBO, basically you see the patients are sitting, they get the 100% oxygen by HEN10 mask or ET endotracheal tube with a special chamber at 2.4 atmospheric absolute pressure for about 90 minutes. So that's each session. The treatment is done 5 times, which is called, each time is called a dive, and it's once a day. And then, here's a little picture to show it to you. So that's what these guys go through for each treatment, and they have to do it 20 times before and 10 times after. Excuse me. So, and this is kind of like, where I'm using some information also based on HBO therapy done for dental extraction, for example. And when you're doing implant, you're trying to do the same thing because the bone has to heal. It has to go through the healing phase like we talked about. So here's a study done, and they talk about post-radiotherapy protocols. So it kind of concurs, same result, that you have to do a good history and examination, confirm the history of head and neck radiotherapy was done, and how it would cause a problem for your particular treatment plan. The urgent referral to the head and neck coordinators, and you got to get the whole oncology team, talk to them, find out what the radiation dose was, like we talked about, and the field of view, and make sure your patient understand what happened in the past, what the risk and benefit were, and they confirm with you, and then it was actually passed on to your patient about the information of osteoradionecrosis with surgery in the mandible. So we talked about numbers here. They recommend anything above 50, for example, to the jaws, that it should go into the HBO therapy. And the protocol we mentioned about 20 dives before, 10 dives after. And we talked about xerostomia in radiated patient. And you need to see them more frequently, make sure they have good cleaning done so the plaque doesn't get built up, no inflammatory response, which can lead to peri-implantitis and possible implant failure. So again, couple of studies or recommendations, basically the same suggestion and protocol for patient with prevention of osteoradionecrosis. So the protocol for the HBO therapy when used prior to implant placement in patient who had radiation done. So if you're looking at what the protocol is, we talked about knowing at what number, at what to, what to look for, and at what time you need an HBO done. But let's look at the bigger picture. What's the complete protocol you would see? So, like we talked about, it needs to be strict oral hygiene regimen before an implant and after an implant placement, especially because of the dry mouth. Use of the longest and the widest implant type. So basically recommendation of over engineering in some cases because you want the more surface area. But that can lead to a little bit of problem too, because the wider you're going, the more drills are you using, and that can generate more heat. But their recommendation is to go long and wide. They also recommend to delay implant surgery until 6 months after radiation is done. They thought, make sure you have a good consent. The patient understands this risk factor. Obviously, you want to remove all other risk factor because you already are in a risk factor by itself. They also talk about the preoperative HBO, which we talked about. And they also talked about maybe leaving the implants 3 months longer. So if you're planning to, in the mandible, let's do, say you used to do 3 months, maybe you want to leave there for 6 months. And if maxilla, you're doing 5 to 6, maybe 3 months longer after that. They also talked about, over-engineering it, which basically you can already see it happening over here. And, they didn't make any distinguish between the mandible and the maxilla. So either mandible or maxilla, they would like you to follow this protocol by itself. So next we talk about chemotherapy. So again, in the same theme of patient with possible cancer, radiotherapy, and chemotherapy. So 3 studies. They could not evaluate the effect of history of chemotherapy on implant success or survival due to the fact that no failures were occurred in these groups. So that itself is kind of indication. But they couldn't make any distinguish, at least on that study. There was another study that found that having a history of chemotherapy had no effect on the risk of failure. So the 2 studies, at least there, pretty much show there was no effect. Scully, 2007, in their review, concluded that there is little evidence that cancer chemotherapy influences the success of implant. This appears to be based only on one study, which is also cited in Wood article. So the pool and the study are not that many to give any conclusion one way or the other. And again, if you want to, I have referenced everything here. You guys can go back and check it out. So our suggestion, basically, what we've seen so far is the evidence is very limited. However, it seems there is no consensus that a dental implant should not be placed in people undergoing active chemotherapy. There is no evidence based on one study and expert opinion that people who have had chemotherapy in the past have any elevated risk or failure. So if you choose to do implants on them, there's nobody's going to come against you, at least based on the studies we talked about. So our suggestion is there is a consensus opinion that dental implants should not be placed in people undergoing active chemotherapy. Even though we talked about patients that were active, there's not much to be found. Our personal recommendation is that, in case not patients who haven't passed, but patients who are inactive, maybe we should avoid it due to the metabolism during the chemotherapy part, or even in some case their own, the health part and recovery part. But by no means it's an indicative of literature where that's an absolute contraindication. But if somebody has had chemotherapy done in the past, we feel like there is no clinical evidence to per se for it, but we do recommend to just kind of wait or watch out if they're actually on active chemotherapy. Effect of coagulation problems. So 3 of the current studies found no significant change in the risk of failure in patients with coagulation disorders. And the other 2 also reported that diseases which include coagulation disorder had no effect on implant failure, which is in line with our experience also. Our suggestion, medical advice should be sought out for patients with coagulation problem. Obviously, if you're doing surgery, you need to have make sure that you as a surgeon are able to handle the complication of bleeding if it arises. And if you do not feel comfortable, you can do that. Again, we recommend referring to your oral maxillofacial surgeon, as they have a training and background to handle these kind of complicated cases. Or taking anticoagulant medication before proceeding with the implant placement. So, um, we recommend that, when it comes to anticoagulation and the medication they're taking, you should talk to their uh, um, physician who prescribed them and be in touch with them. But per se of putting the implant in, there is no contraindication for it. The other effect we're going to talk about is effect of gastric diseases. Our suggestion is there is not much evidence that people with gastric problem have any higher risk of implant failure. Crohn's disease, for example, there was one coherent study that found that presence of Crohn's disease significantly increased the risk of early implant failure, where the OR number was almost 7.8, 8, so close to 7.95. There was another smaller study found that after correcting or clustering, the survival rate of implants was significantly less in people with Crohn's disease. The remaining study found that Crohn's disease had no significant effect on the risk of late implant failure. The narrative review stated that the people with Crohn's disease on systemic medication may show delayed and altered wound healing, and recommended that surgery might be closely monitored. And when we talk about systemic medication for Crohn's, we're talking about long-term steroid use, which can have an effect on healing. Uh, so you can see why that correlation might be there, and more than disease is actually the care of it with medication that might be an issue. So, the problem is, these are again, when we're making our suggestion based on this one's particular medical consideration, but as a physician, always I'm trying to kind of come back and again and keep an eye on the big picture. So our suggestion is there is insufficient evidence that the presence of Crohn's disease is a significant risk factor for implant failure. So we're not saying one way or the other, just the fact that there's not much enough information to actually make a conclusion of how Crohn's disease would affect. But know the fact that if you are on chronic steroid, and we know what the chronic effect of steroid might be on a patient, that it might be not a contraindication, but might affect your success rate. Cardiac diseases, there were 9 papers were reviewed that evaluated the effect of cardiac disease on implant survival and success, including 7 coherent and 1 case control study and 2 narrative reviews. All the studies reported that cardiac disease had no significant impact on dental failure, including 2 that did not report any result for this group at all. So the other 2 narrative reviews reported that although the cardiovascular disease does not appear to affect implant survival or success, people with such conditions may not be a good risk group, and medical advice should be taken, which is kind of common sense. If some people who have really bad cardiac issues or have a history of MI, stent plays, putting stress on them during the surgery might be an issue, and you make sure you want to talk to their primary care and get medical clearance, or they are physically can handle the stress of surgery. And we will talk about this a little bit during the consent, pre-op, and post-op later on in other chapters. So our suggestion is there is insufficient evidence that the presence of cardiovascular disease significantly increased the risk of implant failure. So we didn't find any reason or contraindication to say that you cannot place dental implants on patients with cardiovascular diseases. The next we're going to talk about hypercholesterol. There were 3 coherent studies were reviewed that evaluated the effect of high cholesterol on implant survival and success rate. And then later on there's a table 19 you'll see kind of give you a good summarization. 2 of the studies found that the hypercholesterol did not affect the risk of either early or late implant failure. The other found that the hypercholesteremia did not lead to an increase in failure. However, there were no implant failures in this group. So kind of not make a, it's not conclusive there was any increased risk of implant failure in this group, basically. So that's kind of like a summarization. So just like the other one, our suggestion is there is insufficient evidence that hypercholesteremia is significant risk factor for implant failure. So we don't have enough evidence to make a judgment if it is high risk for implant failure. Next topic is hypertension. There were 4 cohort studies were done and 1 case control study that evaluated the effect of hypertension on implant failure. All of the studies found that hypertension had no effect on the risk of implant failure. So again, there is insufficient evidence that hypertension is significant risk factor for implant failure. Now, this is going to be a little bit long one because we see this all the time, and I'm going to talk about diabetes in nice depth, so be patient with me. The effect of diabetes. So there were 6 papers were reviewed that evaluated the effect of diabetes on implant survival and success, including 1 systemic review, 4 cohort studies, and 1 case series. 8 narrative reviews and 1 consensus guidelines are also included. So we're going to talk about basically all of them, and we'll try to make our suggestion based on that. In the systemic review, the survival rate was 91.7% in people with type 2 diabetes and 93.2% in people without diabetes. So, in their in their systemic review, the difference between the patient with diabetes and without it was from 91.7 to 93.2. Based on that, the author could not calculate a pooled estimate for the difference in survival rate, as there are only 1 study that included both diabetes and non-diabetic patient. On another study, they found no significant difference in risk of early implant failure in people with type 2 diabetes, with the OR less than 1 at 0.25. There were no failures in the group of people with type 1 diabetes. Therefore, any effect on this condition on implant failure could not be calculated. So they didn't have enough failures to make any conclusion. Another study found that people with diabetes had a greater risk of implant failure. Whether the participant had type 1 or type 2 diabetes is not stated. So it was kind of unclear which type of diabetes they're talking about, because they actually, as we know, there's a pretty big difference between type 1 and type 2. The way the patient medicate themselves and they take care of themselves, and the prognosis of these two conditions. Asadi's 2008b reported a significantly greater risk of late failure in people with type 1 diabetes. However, there was only 1 implant placed in a person with diabetes type 1, and it failed, if you have 1 and it fails 100%. And an extremely unlikely true estimate of risk. So, that's not being realistic because of the size of the pool. When considering type 2 diabetes, there was no significant difference in the risk of implant failure. So again, this is kind of what I was talking about, why this might be a problem when if you can't distinguish between 1 or 2, because they play a pretty different role in significance. And again, when there was a failure rate, it was after in the late stage, which kind of talks about the healing part of it, and kind of goes back when I also talked about the use of steroids when a patient with Crohn's disease might be an issue also. The last study reported that disease which include diabetes were not significantly correlated with implant failure. Like the previous study, this study is unlikely to be any validification because diabetes was part of the diseases. They didn't actually report particularly on it. 4 of these reviews state that the uncontrolled diabetes is among the factors that contribute to an elevated risk of implant failure. So it's not just diabetes, you also have to look if patient is actually taking their medication and they're controlled, or they're being uncontrolled. So being controlled and uncontrolled can have a factor. So that's a question that you now know you should ask your patient if they're diabetic, that are they controlled. The evidence base used to reach this conclusion is limited. is based on only one or two studies, and at times only on the narrative review. So it's pretty, so they kind of put things together, use some of the narratives without the numbers, and made their suggestion. Another list, diabetes as increasing implant failure, and that was just one study, and slightly reducing implant success to between 86 to 96. So that's a pretty big margin, citing 5 studies. So again, there is some decrease according to this study of implant failure, or I'm sorry, increase of implant failure within the range of 86 to 96, and they have, decent amount of number, 5 studies. Excuse me. Another report from one study and concludes that endocrine disease, particularly diabetes, may also pose a significant risk for implant failure. So again, this is under the umbrella of endocrine disease, just like the other one where it was under Hong conclude that if glycemic control is inadequate, so we're talking about somebody who's a non-controlled diabetic, according to the HbA1c level, diabetes does not compromise implant success. So in his unique study, he concluded that I'm sorry, let me take that back. In his conclude study is that if they are under control, and diabetes should not be a problem, unlike when they are uncontrolled in the study up here. In contrast, another review and the guideline, they could not come to a definitive conclusion about whether diabetes is a significant risk factor or implant failure. So I'm giving all spectrum of cases and reviews to give you an idea what the general consensus might be in the literature here. So the effect of diabetes, we think the concern surrounding people with diabetes is that the condition may affect the circulation at the implant site, like we talked about, delay healing time and also increase the risk of infection. So a typical diabetic patient is high risk of infection and delay healing. We kind of ingrained that in our head, and kind of like, again, I'm going to go back to the Crohn's disease where there was a little bit of higher rate implant failure was, kind of effect you get from steroids itself. Mimicking the same effect here. When you have somebody who has Crohn's disease and diabetes, you can see the add-on effect, and that can give you a little red light in your head, a red flag. The studies reviewed here suggest that there is very little evidence that diabetes type 2 increases the risk of implant failure by any significant degree. The study with the largest number and the only one assessed were about 2 plus, found, no significant difference. However, the number of people with diabetes was not reported, so it is not possible to estimate the power of the study to detect a difference. The STEMIC review, on the other hand, found an absolute difference in survival of 1.5%. So there is statistical difference, but how much difference does it make that you will actually make it a contra? No. Between those people with diabetes type 2 and those without. So, you see a 1.5% difference. And again, this is the number you should then communicate it to your patient that, hey, it's still very safe, still very small difference between a controlled person who's not on, if he wasn't diabetic. But there is very, very slight high risk factor, but not enough to stop from getting implants done. Whether this is due to true effect, bias, confounding, or chance cannot be ascertained with any certainty. So they basically protected themselves. Okay. So going through all those literature and review, our suggestion is there is insufficient evidence that well-controlled diabetic patient, like we talked about type 2, is a significant risk factor on its own for implant failure. So if you are type 2 diabetes and you're controlled, you don't have any higher significantly risk factor, 1.7%, not something that you're going to make patient not get the treatment plan done. There is also no evidence whether diabetes type 1 is or is not a risk factor. So for us, we're not making conclusion either way when it comes to type 1. But for type 2, if the patient is controlled and the only condition they have is type 2 diabetes, we don't find that as a contraindication and the risk is low. Next, we're going to talk about asthma and pulmonary diseases. Al-Sadi also found out no effect of the presence of asthma on the risk of early implant failure. On his 2008 study, he found no effect of asthma on late implant failure, so early or late. On 2008b, he found that the presence of asthma did not increase the failure rate. And Moy 2005 reported that pulmonary disease did not have a significant effect on implant failure. So based on that, as much as we could find, we can say that there is no evidence that asthma is a significant risk factor for implant failure on its own. But also keep in mind, some of these severe asthma cases, patient might be on chronic steroids, and that might play a role, especially if they're on other steroid issues. So even though, again, this is for a single issue of asthma, but keep in mind that there might be some other cause that might cause a problem. But again, patient with asthma, where we didn't find any statistical significant risk for implant failure. Rheumatoid arthritis. 3 of the current studies could not evaluate the risk of implant failure, as there were no implant failures in people with rheumatoid arthritis in any of these papers. So we didn't have enough data to determine one way or the other in those studies. The other current study reported that disease, which included rheumatoid arthritis, had no effect on implant failure. There was a case-control study that reported that there was no significant increase in risk of implant failure with the OR of 1.36. Our suggestion: there is no evidence that rheumatoid arthritis is a significant risk factor for implant failure. But at the same time, again, they might be taking some medication that in long term might not be a contraindication or even increase the risk factor, but with the additive effect of other, let's say, steroid therapy, or maybe patient with diabetes, it's still not a contraindication, might be, but at least let the patient be aware. But by itself, the disease and there statistically didn't show any kind of significant risk factor for implant failure. Thyroid diseases, there were 5 papers. They were reviewed that evaluated the effect of thyroid disease on implant survival success, including 4 current studies and 1 controlled study. 2 narrative reviews were also included. All the studies found that thyroid disease did not increase the risk of implant failure significantly. And these are the study basically kind of confirming what we talked about earlier. Again, the 2007, 2008, A and B, both studies. And our suggestion, there is insufficient evidence that thyroid disease is a significant risk factor for implant failure. I'm just going to summarize this because, again, this is such a wide topic, a lot of, so many different type of medications, subcategories. But there were 3 current studies found no association between having a medically compromised condition or disease, including cardiovascular disease, some type of allergies, blood clotting disorders that we talked about, diabetes, hepatitis, tuberculosis, HIV, thyroid, osteoporosis, rheumatoid, basically all the things we talked about throughout this whole presentation right here, or past history of any medical condition and dental implant failure. Medication-wise, there were 3 studies that concluded that taking steroids medication was not associated with implant failure. Elvem in 2008 also found no association between taking no medication or taking antihypertensive, statins, antibiotics, or NSAIDs, or any kind of hormone replacement, and with any risk of implant failure. In Al-Sadi's 2008, he found no association between taking antidepressant medication and implant failure. So here it kind of broke it down to different type of medication. There was no kind of direct correlation if you're on steroid by itself or if you're taking hypertension medication had any effect on implant failure. In regard to antibiotics, there was 1 study and found no relationship between taking antibiotics at the time of implant surgery and implant failure. There was another study found that people who were allergic to penicillin had a greater failure rate than those people who were not, but the statistical significance is unclear. We have another study that found no correlation between implant failure and taking any single medication or a combination of medication. So, again, you kind of have to look exactly what uh, they went on and which medication or subtype they included to have a better idea. But there was no red flag that's look up. So you can go back in our reference 37, and if you want to look at the article, you can see what were the exact medication. But in general, nothing red flag came out. So all three narrative reviews stated that systemic bisphosphonate medication was the contraindication to implant placement due to the risk of osteonecrosis. Again, we covered that on a subject by itself, so that one was kind of expected. So our suggestion based on the evidence, there is insufficient evidence that any medical condition other than those we actually talked about is a significant risk factor for implant failure. So there might be, we're concluding based on what we reviewed so far. There might be something that wasn't part of this chapter that might be risk, but at least for our part of it, all the conditions were talked about. There is insufficient evidence that steroid, antidepressant, antihypertensive, statins, antibiotics, NSAIDs, medication are significant risk factors. So again, there might be some reduction, but it's not significant enough to make any kind of determination that, hey, this patient should not get implant. So there's no absolute contraindication related with it. Bisphosphonate medication is a contraindication to implant placement due to its risk of osteonecrosis, but we went on in further detail in breaking it down with the CTX and having to have 150 and above. But if you, like I said, in these kind of cases, always recommend send it to your oral surgeon. They deal with these things all the time. They know how to handle these complications. But if you feel confident, we went over it, how to prevent osteonecrosis by the CTX model. So this is another nice, and you can, like I said, anytime the presentation, you can pause it and kind of go over it. What I also did was we kind of took individual contraindications and indication. And I'm not going to go over all this again, but the authors are there who have made with their experience and their review have put what are the medical contraindications for example. In this case, they recommend if there's an acute infectious disease. For them, it's an absolute, don't do dental implants. Like we talked about, one of the only thing we talked about was the active chemotherapy, where you don't want to do any implants. Systemic bisphosphonates, severe psychosis, depression, and again, that's relative, not even absolute. Pregnancy, because of the medication. The growth factors, we talked about that too on a child, for example. So that's the contraindication from the medical point of view. So this is a nice reference to have. So what I did was, this was one. Here's the other one. We talked about disease and assessment, and they talked about uncontrolled diabetes. That was one of them we discussed also. HIV in some cases because of the medication sometime, but also the infection part of it. Patients are prone to infection if you're doing surgery. Alcohol, drug abuse. Then again, remember we talked about the cigarette greater than 20 had some type of significant risk when it comes to implant failure. So this is their recommendation in 2005. They have their positive factors and negative factors. So this is kind of like a nice little review too. What is good, what you're looking at when you're looking at what's an ideal situation. And we'll go over that a little bit when we talk about patient selection and case selection part of it, right? So you're looking for type 1, type 2 versus negative would be 3, 4, and pretty consistent theme where you find this in the maxilla, right? Obviously, bone volume, age, it's not really a factor, but it could become a factor due to osteonecrosis post-menopausal, so be understanding of that. Our cases, again, it's anecdotal, but me, my partner, I remember doing residency, our failure rate were going down and down as the more we have practiced. And part of it because we understand these risk factors, our surgical technique, our flap designs, our case treatment plan. I would say one of the big ones that is, you have better understanding of it. So clinical experience makes a difference. Um, so again, so this is another breakdown of kind of indication, contraindication wise, but not more like contraindication, but risk factors, let's say. So here's another example of study that I found, 2006-7. He did his own absolute contraindication, recent myocardial infarction, valve prosthetic, immunosuppression, bleeding issues. Now, like I said, not everybody disagrees with it, but if you are a surgeon, you know how to handle these things. This is not an absolute contraindication for you. Malignancy, drug abuse, psychiatric issue, IV bisphosphonate. Again, it might not be, for at least for me, it's not an absolute contraindication because we have a certain protocol that we follow and we are equipped to handle our complication as a maxillofacial surgeon. But I do recommend for general dentists who's, a patient who are on IV bisphosphonate, especially recently, and their CTX is marginal, to send to their oral surgeon. And then they talk about he talks about the relative contraindication, and I don't find this a relative contraindication. But again, you see, I'm trying to present all point of view, so you make your own independent study, not my particular bias in it. So in conclusion, the evidence for significant risk factor for implant failure is summarized as follows. Smoking. Smoking as a single risk factor may not increase the risk of failure sufficiently to deny treatment. All right, so we discussed that pretty hard. But dental implants may be contraindicated in smokers who have other relative risk factors, so, problem by addition. In addition, smokers seeking the dental implant treatment should have their smoking history taken, be advised of the risk of implant failure, and advised to stop smoking. I always I make sure in my consultation, patient medical history is nicely understood, and you can verbalize them the risk factor. Because when something goes wrong, and when you explain them beforehand, and they accepted the risk factor and they took it upon themselves, even when it fails, the transition and their acceptance is much better when you do not explain this to them and then tell them, oh, why did you smoke? Well, what do you mean, why did I smoke? So, these numbers are very small, but at least you have a reason if it doesn't work instead of, hey, I don't know what happened. And the patient also understand what they're stepping themselves into. Age, older age, a single risk factor is not a contraindication from our point of view. Radiation, there is some evidence that implant failure rates in the maxilla we talked about significantly increase in the people who have previously radiation done on the maxilla, regardless of the total radiation dose. And knowing that how blood supply is affected, we know that maxilla is usually D3, D4, and with already a weak bone, there is some issue that beyond the maxilla, but by any means is not a contraindication. Sorry. And then we also talked about radiation, about the HBO treatment for a patient who had 6,000 CGY or above. Excuse me. Chemotherapy, there is no consensus opinion that dental implants should not be placed in people undergoing active chemotherapy. So, that's the conclusion that we had on the paper. But personally, for me, my suggestion is if you are going to chemotherapy and you're actively, I do personally do not put implants in those patients. I wait for the treatment to be over, and then we do our elective procedure. Coagulation disorders. Medical advice should be sought out for people with coagulation disorders. So first thing first, when you're doing surgery on a patient with high-risk bleeding, make sure you know how to handle bleeding complication. If you're not, you send it to the oral surgeon. But even then, you should be able to communicate with their patient, with their primary care physician, or who is taking care of their anticoagulation. Sometimes they would adjust the dose or even stop it. We don't stop it because, like I said, we feel very comfortable with handling bleeding complication, and we feel the stopping of the anticoagulation is actually more risk to patient than the bleeding, which I can control. Bisphosphonate medication, we went over in great detail about bisphosphonate. So bisphosphonate medication is a contraindication to implant placement due to this risk of osteonecrosis of the jaw. And based on the CTS result, one should determine what the impact of the bisphosphonate has been. So it is a contraindication depending on the CTX result. And then we talked about going in holiday period, and every month you can gain about 26 pg per ml to get over the 150, and then you can have less risk to be able to do the surgery. But like I said, do procedures that you can handle the complication. And my recommendation for young guys who or anybody who is novice in putting implants or even surgery, if you're not an oral surgeon, I would not touch this, especially if it was below at 150 at one point. If they're in safe range and 150 and above, and you have a good referral system where if something happens, somebody can help you out, then yes, go ahead and do it. And it is predictable to be 150 and above. Diabetes type 2. We talked about there's insufficient evidence that well-controlled diabetes type 2 is a significant risk factor. We also talked about if it's not controlled, there was some evidence that there is high significant implant failure. There is no evidence whether diabetes type 1, asthma, rheumatoid arthritis is or is not a significant risk factor because of the lack of numbers and the type of studies that were done. So, in general, there is insufficient evidence that the following factors are significant risk factors for implant failure. So, you could be pretty safe about these guys. Hormone therapy done, postmenopausal. Again, we're talking about these issues by themselves, but understanding we talked about little Crohn's disease and knowing what medication they're taking, there could be some additive effect, but by itself, at least from our point of view, there's insufficient evidence that they will cause some high risk failure. And these are references you can kind of go back and do the literature review on your own if there's any particular studies that you saw up there. So again, this concludes our lecture on it. It was a pretty long lecture, and you could have paused anytime. That's what I recommend. Just take a break sometime. And it's also a good thing that you can always come back a year from now, 2 years from now, and kind of review this thing as much as you can, because we see these things all the time, and these things do affect our treatment planning. And now you can slowly see how our program is directed, where you learn about bone, soft tissue, and you can see these impact of these disease and medication have on them, on the clinical, from pathophysiology to pharmacology to clinical point of view. And all of that information then help us treatment planning, where when to over-engineer, when not to over-engineer, when to tell your patient at what risk factor it is, and when to take a step back and actually refer it out. Because the last thing you want to do is jump on something you can't handle. And my course is designed to make sure that you're educated enough that you can make a clinical decision when to take a step back and when to refer it out. All right? Thank you very much.